and thank you everyone for joining us today. I, Amit Saxena, along with my teammate from Jagsonpal Pharmaceuticals Limited, Dr. Deepika Chhabra, are delighted to welcome you all today to the academic session on demystifying hypothyroidism in women by esteemed experts. Today's discussion are brought to you by Jagsonpal Pharmaceuticals, makers of DIVATRONE, the first and fully indigenized micronized dydrogesterone with clinically proven bioequivalence. DIVATRONE is entirely manufactured in India. Particle size of DIVATRONE is smaller than 10 microns, ensuring greater bioavailability. DIVATRONE is only dydrogesterone's brand in India with 36 months of shelf life. A warm and hearty welcome to esteemed experts, attendees. Dear attendees, please, we request you to post your questions, suggestions, clarification by text in Q&A box. Please note this webinar is streaming live on Facebook and the link is already shared in the chat box. To refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. As we initiate the session today, we request Coordinator Dr. Kiran Sinha ma'am, Secretary ISOPARB Kanpur Chapter to kindly initiate the session.
Thank you, Dr. Amit. Good evening, everyone. I, Dr. Kiran Sinha, Secretary ISOPARB, welcome you all for today's very important meeting, that is hypothyroidism in a woman life across all ages. As all of us know, that it affects women at every age and almost can affect any system of the body, and most of the time the patient, they come themselves with the thyroid report. Then we gynecologists, as we are physicians to them also, apart from their gynecological problem, they ask, Madam, kya lena hai? Then today, to solve all these dilemma and the queries of us gynecologists, nobody can be better than Dr. Anurag Bajpai. He is a great endocrinologist of the town, and he has given his very kind consent for this topic. So, not taking much of the time, now I invite Dr. Sangeeta Arya, who is moderator of today's program. Dr. Sangeeta, she is HOD and Professor, Banda Medical College. I hand over mic to Dr. Sangeeta. Kindly go ahead, Sangeeta, Dr. Sangeeta.
A very good evening to all. We welcome you all in today's webinar on demystifying hypothyroidism in women. As Gangadhar Sahoo, President ISOPARB, sir is also with us. We have got our chief guest, Dr. Meera Agnihotri ma'am, our patron Kanpur Society, as well as we have got guest of honor, Dr. Pragya Mishra ma'am. She is Secretary Secretary ISOPARB, National Secretary ISOPARB, along with our senior patron members and the ex-president, as well as the President ISOPARB, Dr. Neelam Mishra ma'am. So to just start without wasting any time, I would request, along with our speaker, the very learned speaker, Dr. Bajpai sir, to kindly join us in the evening prayer, but just to get the positive feelings as well as to imbibe whole of the energy inside.
Ya Brahmachyuta Shankara Prabhutibhi Devai Sada Vandita Sama Patu Saraswati Bhagavati Nishesha Jadyapaha Shuklam Brahma Vichara Sara Parama Adyam Jagat Vyapinim Veena Pustakadharinim Abhayada Jadyandhakarapaha.
Thank you, Deepika ji. Now I invite our President of Kanpur Obs and Gynae ISOPARB Society, Dr. Neelam Mishra ma'am. She is the Director and Chief Consultant of Shivani Hospital. Recently, we have done a super IAG conference under her guidance. I invite Dr. Neelam Mishra ma'am to present her welcome address.
Thank you, Sangeeta, for kind words. Good evening. I welcome you all on today's meeting of Kanpur chapter of ISOPARB. Today's topic is Demystifying Hypothyroidism in Pregnancy. I welcome dignitaries, our chief guest, patron at ISOPARB, Dr. Meera Agnihotri. She's just joining, and the past president of ISOPARB Society. She's teacher of teacher, president of WWCon Foundation, and Madam is the chairperson of IAG Kanpur also, which was held in 14th and 15th May with a great success. So welcome, Madam. I'm very grateful to have with us Professor Dr. G. Gangadhar Sahoo, our learned and energetic newly elected president, ISOPARB, in today's webinar. Thank you so much, sir, for joining. Sir is a retired professor and head of Department of Obs and Gynae, VSS Medical College, Burla, and is a dean of Institute of Medical Sciences and some hospital. He is a pro VC in Shiksha and Anusandhan. His dream is to be a ladder of success for others to climb up, an ordinary man surrounded by extraordinary friends and well-wishers. Thank you, sir. I would also like to extend my warm welcome to our dynamic secretary, newly elected, Dr. Pragya Mishra Choudhary. Madam is a consultant infertility specialist at New Life Test Tube Baby Center and MGM Hospital and Research Center at Patna. She is a Secretary General of ISOPARB from 2022 to 24. Madam was the chairperson of Genetic and Fetal Medicine Committee, FOXY 2016 to 2018. She is a founder secretary of Bihar chapter of ISAR, vice president of Patna Obs and Gynae Society. She is a secretary of Patna Obs and Gynae Society. She is examiner for MRCOG in clinical examination. She imparts FOXY certified colposcopy training. She was awarded with the Asia GCC Award 2021 for excellence and leadership in IVF, gynecology and obstetrics. She was awarded Healthcare Professional of the Year 2018 in Bihar Gynecologist, awarded the George Mahoney Award in 2014 by RCOG, awarded by CL Jawari Award at 57th AICOG 2014, awarded by J. Mishra Gold Medal Award in 2018, and so many. She has contributed 10 books and papers in national journals, organizing secretary of FOXY in GEMCON 2018 Patna. She is a scientific chairperson of ISOPARB Annual Conference of 2016 in Patna, and our speaker is none other than the Anurag Bajpai. He is a consultant endocrinologist from the Regency Hospital who doesn't require any introduction. He is a very competent, very hardworking endocrinologist of the town. Today's chairperson of this conference is the none other than always smiling Dr. Usha Goenka, president of Kanpur Obs and Gynae Society and the vice president of Kanpur ISOPARB Chapter. The expert of this program is our dynamic professor, Dr. Kiran Pandey, head of Department of Obs and Gynae, GSVMMC Medical College, Governing Council member, and chairperson elect Medical Education Committee. Thank you, madam. Today's program convener is none other than my very efficient and hardworking secretary, Dr. Kiran Sinha, and the moderator is Professor Dr. Sangeeta Arya, who is the communicator of the ISOPARB Kanpur Chapter. There is a question answer session after this program, which is prepared by Dr. Vinita Avasthi, treasurer of ISOPARB, and Dr. Rekha. Kanpur ISOPARB Society is blessed with the galaxy of dynamic and very competent dedicated office bearer. And for this task, we do our level best for the progress and growth of the society, sir. There is no doubt that the obstetrician is the best person for the primary and the essential care. And this unique society also extends its membership to those who are interested in the reproductive biology. The reproductive biology in general covers the general health, including the social and sexual health, and the gender equity start from the young adolescent girl to the postmenopausal woman. So in sum, ISOPARB covers many interrelated disciplines. Besides being pure obstetrician and gynecology, it extends its partnership with the neonatologist, pediatrician, endocrinologist, physician, and many others. So ISOPARB is working closely with other disciplines to ensure quality care in overall total women's health care. So thank you, Sangeeta, for all. And now I'll invite you for further. Over to you.
We have got a very special day today. We have got birthday of our president ISOPARB, Dr. Neelam Mishra ma'am.
Thank
Happy
you so
birthday, Dr. Neelam.
Happy birthday, ma'am.
much.
Music.
Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday, happy birthday to you.
Thank you
डॉक्टर
so
नीलम
much.
हम लोग आपकी एनिवर्सरी बर्थडे सब से साथ
साथ मना रहे हैं क्या है? इससे अच्छा और क्या हो सकता है किरण जी?
बिल्कुल बिल्कुल कितना ये बढ़िया कोइंसिडेंसेस हैं.
Ma'am, we wish you a long, happy life.
Thank you, sir.
आप हमेशा blessings देते रहे. Thank you, ma'am. Ma'am, we further proceed with our program. We have got our chief guest, Dr. Meera Agnihotri, ma'am. Actually, we have got some weather problem at Kanpur, so Meera ma'am is not at present able to join. We are helping her to join because she is all alone at home. So I invite our chief guest, Professor Gangadhar Sahoo, sir, to kindly say a few words of blessings. He is the president ISOPARB. Sir, we are very thankful to you that you have joined with us. Over to you, sir.
Okay. Thank you, Sangeeta ma'am. Namaskar. So, at the outset, my namaskar to all the esteemed guests, office bearers of ISOPARB Kanpur Chapter, office bearers of OBGY Society of Kanpur, and their delegates or the audience who are attending this webinar. My greetings from Bhubaneswar and Odisha, and blessings from Lord Jagannath. So again, I wish on behalf of the ISOPARB, happy birthday to Neelima madam. So may Lord Jagannath bless her with a healthy and happy life. Thank you, madam, for inviting me. Thank you, Kanpur chapter, for inviting me as one of the guests or chief guest for this evening. So as I said, few words about me. I am a grassroots isoparbian. I have been a member, live member of more than 10 societies or 10 organizations, but I have concentrated on one, that is ISOPARB, and ISOPARB. For this, my mentors Sindhu Nandin Tripathi, SN Tripathi, and D. Pushpalata from Hyderabad, they have nurtured me from the grassroots level to this level. Still, I am a worker, maybe a leader. Then about ISOPARB. ISOPARB is, as I said, it is in a growing stage. So there is a spot in the growth, particularly in the adolescent period. So similarly, this is the adolescent period of ISOPARB. It is growing very fast. The example is your Kanpur chapter. So it has shown the path that we can grow. We can increase in membership in spite of if we have to pay 10,000 rupees to the central body. So we will not stop there. So regarding the theme of this year or slogan of this year, that is, let us walk the talk. That is a very simple theme I have chosen, that we should work. In the annual conference at Banaras, I had said that if every isoparbian think of ISOPARB or work for ISOPARB for 15 minutes, then I will give you the ISOPARB of your dream. So therefore, we all the isoparbians, along with our brothers and sisters of OBGY Society and other societies like pediatricians, endocrinologists, whoever are there. So everybody should work together as a team to take the ISOPARB into the next level. Then about the topic. So hypothyroidism is so common almost in every OPD you will be finding such cases, whether it is a gynecological case, whether it is a fertility related problem, whether it is a menstrual problem, or during pregnancy. So both hypo, hyper, subclinical, everything is important to diagnose early and treat it early during pregnancy. So there is no other person except Dr. Bajpai. Welcome him as the renowned endocrinologist of the city. So he will apprise us with the knowledge about the basics about thyroid problems in pregnancy. So once again, I wish you all the best. Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pasyantu, ma kaschid dukha bhavet. Wish you all the best. Hopefully it will be enjoyable, interactive session in this evening. Thank you, madam.
Thank you, sir. From the whole ISOPARB Society of Kanpur, as well as Kanpur Obs and Gynae Society. On the screen, we are able to see our patron, senior patron, Dr. Meera Agnihotri, ma'am. And you can see my smiling face. We are so relaxed to see her. Ma'am, we always seek your blessings to start our any program. So, Dr. Meera Agnihotri, ma'am, is our senior patron, Kanpur Obs and Gynae Society. She has many awards to her own. She is owing lots of awards, and I hand over a mic to Dr. Meera Agnihotri, ma'am, to seek her blessings. Over to you, Meera, ma'am.
Can you hear me?
Yes,
ma'am.
yes.
Yes.
Ma'am, namaskar. At the outset, I
Namaskar.
have taken your position, first position. So I am sorry for that. So, madam, welcome. Welcome
You have
to
taken the
this.
correct seat. Driving seat is always very important. So I'm very thankful to you to take the driving seat. At the outset, I extend my heartfelt gratitude, love, and blessings to all the organizers and Kiran, Sinha, and Neelam Mishra, Sangeeta, and whole our President Dr. Usha Goenka, Kanchan Sharma, and all the societies who are participating. This is a very, very important subject which they've chosen. And I tell you, in spite of so much thought has been given to it, we keep on reading every day, we keep on learning with every patient. Because Dr. Bajpai will be telling it in different age groups. Kiran has told me very nicely that he will be discussing everything. I personally feel this is a very, very important seminar from the point of view when we are dealing our patients in the childbearing age, especially when the patient is pregnant, then the readings must be, they keep on changing. And what should we do if it is a borderline one, or if there is a symptom but it is a normal one? Sometimes we are, you see, otherwise it is a cakewalk, but sometimes it becomes a nightmare, and we have to look after the baby as well as the mother. So I extend my heartfelt gratitude, love, and blessings once again for this wonderful meeting. And Dr. Bajpai is well known to not only this city, but all over the state and rather country. His endocrinologic, you see, equipment is known to all of us, and his way of teaching is also very excellent. I personally feel that he will come up with wonderful suggestions, outlines, guidelines for the management of the thyroid. So thank you once again for you for taking the driving seat. It's very comfortable to sit on the back seat because the onus goes to the driver and enjoyment goes to the backbencher. So thank you once again for taking this thing. And I again congratulate Dr. Kiran Sinha, Dr. Neelam Mishra, and our President and Secretary Usha and Kanchan, that Kanpur Obstetrics Gynecology and ISOPARB, they are working very, very hard. And I extend my thanks once again to Sangeeta, who is teaching me how to technically, you see, accommodate in this situation. Dr. Saab, I'm very poor in technocracy, so I will keep on learning how to connect easily and join it. So thank you once again. Please go ahead with the academic session.
Thank you, Meeraji. Thank you, madam.
Thank you, ma'am. This is our honor and privilege, ma'am. I now invite our guest of honor for today's evening, Dr. Pragya Mishra, ma'am. She is the National Secretary of ISOPARB. Ma'am, we are so thankful to you because I know you have to go to other webinars also. Thank you for taking out some time for us. She is the immediate past chairperson, Genetic and Fetal Medicine Committee, FOXY, and she has taken many prestigious chairs, and she has done her work very nicely as being a treasurer, vice president, secretary of Patna Obs and Gynae Society. She has been awarded by many prizes like Dr. C.L. Jhaveri Award, J. Mishra Award, MP John Gold Medal in Boxcon, and many more. Over to you, ma'am. Dr. Pragya Mishra, ma'am.
Good evening to all of you. And at the outset, I thank Dr. Sangeeta for such kind words, and Dr. Neelam Mishra also for having given a very generous introduction of mine. So, chief guest of today's webinar, Dr. Meera Agnihotri, Dr. President of ISOPARB, Dr. Gangadhar Sahoo, President of Kanpur Chapter, Dr. Neelam Mishra, Vice President, Dr. Usha Goenka, and Treasurer, Dr. Vinita Avasti, and Communicator, Dr. Sangeeta Arya, and all the members of Kanpur ISOPARB Chapter who have actually, and members of Kanpur Obs and Gynae Society who have all logged in today for today's webinar. And I must congratulate ISOPARB Chapter of Kanpur for having shown so much enthusiasm. Although I know it's a small webinar with one topic, but the topic has been meticulously chosen, demystifying hypothyroidism in women. And the speaker also has been really chosen so meticulously. I'm sure he's going to do justice to the topic. Although it's a small webinar, but you know, the enthusiasm shown by the president, Dr. Neelam Mishra, and Dr. Vinita Avasti and Dr. Sangeeta Arya, you know, so many calls, you know, just to ensure that, you know, we are all logged in on time. So that's really great because, you know, I'll tell you, yesterday I was in an international platform where they had to do my recording. And I was actually logged into the Lucknow chapter of Gorakhpur chapter of ISOPARB program. And I've totally forgotten that, you know, the recording was to happen yesterday only at 7. And I was logged in a different program for that Gorakhpur Yuva ISOPARB. Suddenly I saw this message flashing saying that, that, you know, if you remember that your recording is in 10 minutes time. So I just thought, you know, that I wish they had like messaged me in the morning, a reminder. And, you know, like just to see, you know, our own people, you know, so, I mean, there's so much of warmth which you all are emancipating, you know, with multiple phone calls. So thank you so much, ISOPARB chapter of Kanpur chapter of ISOPARB, and please continue to show the same enthusiasm. And recently, Dr. Kiran Sinha had messaged me saying that, you know, she has made some, you know, few more members. So I congratulate you for making the new members for the Kanpur chapter. And I wish you all the best for this webinar, and also wish you the same for what you're going to do in the future. And it's so enthralling to see, you know, how ISOPARB, I mean, really, you know, has become so active, especially like in the Kanpur chapter, Aligarh, and you know, all the chapters in the North Zone have suddenly become really active. So we are really proud of you, and I'm sure that, you know, you all the chapter, city chapter presidents and secretaries with their efforts, I'm sure you all are going to take ISOPARB to greater heights. So thank you so much for showing this keen interest. I'm sure Dr. Sahoo must be so thrilled, you know, for having, he has recently taken over as the president, and myself, and we are so delighted to see the zeal and enthusiasm which you all have shown. So thank you, and wish you all the best.
Thank you. Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you, ma'am, for your kind words. Definitely, ISOPARB Kanpur will do a great work in future under your guidance. Now we further move on to the main topic of today for the today's webinar on hypothyroidism. Ma'am, as you have said, we have taken only one issue for today's webinar, and we have heard our speaker, Dr. Anurag Bajpai, many a times. When Kiran Sinha ma'am was saying कि बस उनको तो जब सुनो तो सुनते ही जाओ, लगता है कि I should like hear him many a times. तो उनको सुन के when we feel like we get lots of knowledge from him. So over to today's session, main session. For this, I invite our chairpersons, Dr. Neelam Mishra ma'am and Dr. Usha Goenka ma'am. And for today's session, we have got our expert. She is my own teacher, Dr. Professor Kiran Pandey ma'am. She is at present heading the Department of Obs and Gynae. She has won the ICOG. She is the ICOG Governing Council member for 2021-22. She is the President Kanpur Menopause Society, Chairperson of IMA WDW 2019 till date. She is the Vice President UP COG and UP AGOI, ex-principal GMC Kannauj, and she has bagged many awards.
For very kind words.
Literally, we are very happy to be to have an expert like you in our today's session. And our President, Dr. Usha Goenka ma'am, and President ISOPARB, Dr. Neelam Mishra ma'am, will be chairing the session. I hand over the mic to Dr. Usha Goenka ma'am to kindly introduce our speaker, Dr. Anurag Bajpai sir.
Thank you, Sangeeta. Good evening, everyone. Thanks, ISOPARB Kanpur Chapter, for making me a part of this webinar. My pranam to Dr. Meera, my guru, Dr. Gangadhar Sahoo and Dr. Pragya Mishra. This is my present privilege to introduce Dr. Anurag Bajpai, our speaker. Dr. Anurag Bajpai is consultant pediatric and adolescent endocrinologist, Regency Hospital, Kanpur, and Fortis Memorial Research Institute, Gurgaon. He is Secretary Treasurer, ISPAE 2017-18, Secretary Growth Society, Director Med E Classes, Section Editor, Endocrinology, Indian Journal of Pediatrics, Sorrel Catherine Freeman Prize for Best Postgraduate in Pediatrics at All India Institute of Medical Sciences, FRA CP from Royal Australian College of Physicians, trained at Royal Children's Hospital, Melbourne, editor of 6 books related to pediatric endocrinology, book chapters in 36 books on pediatric endocrinology, more than 40 index publications in pediatric endocrinology, over 300 presentations in state, national, and international conferences. Wonderful, Dr. Bajpai. We Kanpur people are very lucky to have Dr. Bajpai in our city. Welcome, Dr. Anurag Bajpai.
Thank you, ma'am. And it's indeed a pleasure and an honor to be part of this program. And many thanks, Dr. Kiran, for allowing us to interact on this issue. Thanks, Dr. Gangadhar, Dr. Pragya, Dr. Sangeeta, Dr. Neelam, Dr. Kiran, Dr. Usha, Dr. Meera for kind words of introduction. And I think we can start the session now.
Yes, sure.
Okay, sure. So hypothyroidism and thyroid disorders are one group of disorders which are encountered across specialties. So it is one of those diseases which everybody will be encountering at one point or the other. And we are seeing a significant increase overall in terms of these disorders. So I'll try to do over the next 30-40 minutes or so is to take a bird's eye view about how a woman may be affected by a thyroid disorders across lifespan. So we'll start from the newborn age group to go really like the issues related to the growth in young age group, then fertility issues, pregnancy issues, and subsequently older individuals, how do we go forward? So I'll start off with one of those tragic cases, which I always start off. And this is something, a reminder that this should never happen again. A 22-year-old lady. And when I say 22-year-old and you see the person out here, you can really see how much shocking was it for this child to come to us. A 22-year-old with severe short stature, equivalent to a 4-year-old child in terms of height, extremely coarse skin, and all the features of hypothyroidism. Now, this is the extreme form of missed form of congenital hypothyroidism, which presented so late with having a huge implication. So there are implications. Thyroid disorders are easy to identify, easy to evaluate, easy to treat, but the key is that we often either miss or mess in that regard. So this is something which we should never be missing in that perspective. Another scenario for 25-year-old lady who had recurrent miscarriages and presented with a TSH of 3.1 and TP of 1000. I'll discuss about the various ways in which the evidence is about how she would have or should not have been treated. Now, unfortunately, during pregnancy, no treatment was done, so miscarriage happened. So there are a lot of subtle issues in terms of thyroid disorders. We now have availability of the test, availability of the treatment specialties, specialists. We need to probably move a level up to have good care in that regards, and we'll try to focus about the different aspects out there. So you all can go and have a look at our website, Mediclasses, learning.growthsociety.in, which provides extensive resources on endocrine learning, validated tools and practical tools for assessment. We have recently come up with a pediatric and adolescent gynecology course, which covers around 20 modules covering each and every aspect of pediatric endocrinology. And we have recently launched a Mediclasses gynecology app, which allows comprehensive approach, evaluation, and management of complicated disorders, and I'll show how we are using it in terms of thyroid disorders in particular. It is going to act in terms of assist, providing consultatory role as well as reference information in that regards. It combines the use of approach pathways, which basically use an algorithmic way of question and answer, which provides a specific diagnosis to a wide variety of conditions. There are also management pathways, which also work in terms of algorithmic approach. And finally, there are interpreters, a huge number of interpreters, including a thyroid interpreter, which really interprets the results. So we'll try to see how this can help point of care, precise management, and quality improvement in terms of management. Now, when I talk about thyroid disorders in women, we start right from the initial phase, and we all know that thyroid is the major regulator of growth. It is present in around 1 in 2,500 will have hypothyroidism at birth. And as we saw from the first index case, it can have huge implications. It then affects growth and puberty, again 1 in 250. There are impacts with regards to fertility and, of course, pregnancy. So I'll try to cover each of them using case-based scenarios. And at the end, we'll have Q&As also on case-based scenarios to discuss it further from that regard. A few words about physiology, because this is all which will decide about the different aspects and intricacies. So we all know that the hypothalamic-pituitary thyroid axis involves the TRH, which acts on its receptor to produce TSH from the pituitary, which then acts on the thyroid to produce T4. Now, T4 is largely a prohormone. This has to be converted or activated using a monodehydrogenase enzyme into T3. Both T4 and T3 are largely bound to thyroxine binding globulin. Only 0.03% of T4 and 0.3% of thyroid T3 hormone are actually free. And it is this free hormone which is responsible for all the effects of thyroid hormone. So in scenarios where there is abnormality in the thyroxine binding globulin, like in the setting of pregnancy, in the setting of intake of estrogen, we will have discrepancies in terms of the total hormone and the free hormone, and this can cause confusion, which we'll illustrate in that perspective. Now, T3 is the major active form. It acts and it basically has a feedback inhibition of the thyroid hormone, reducing the TSH level. So in anybody who has got a primary hypothyroidism, the first thing to go up would clearly be the TSH level, which will be the best marker for primary hypothyroidism. Only when the TSH response fails, you will have a fall in T4 level, and the fall in T3 will be the last, because there would be the other mechanism which will compensate that in that perspective. Now, TSH has got a structural homology with other glycosylated peptides like FSH. It will act on the FSH receptor, and this will result in a situation of large ovarian cyst, causing peripheral precocious puberty and short stature with precocious puberty in girls. So if you have any young girl who has got a large ovarian cyst, before you do anything, including tumor markers, look at TSH levels, because that may be a very reversible form of ovarian cyst in that scenario. Now, whenever there is hypothyroidism, the body wants to compensate it. It will increase the activation of T4. So the T3 level will be largely preserved. Having said that, what it means is that T3 is the last thing to fall, and it is the most unreliable marker of hypothyroidism. So I would say T3 is a useless test in hypothyroidism setting. Its only role is in the setting of thyrotoxicosis to identify what is known as quote unquote T3 toxicosis. Now, there can be another situation if there is a hypothyroidism for a long duration, you will have stimulation of the thyrotropin releasing hormone. And this TRH actually also stimulates prolactin. So anybody who has a primary hypothyroidism will have hyperprolactinemia, and therefore thyroid function should be assessed comprehensively before going ahead and doing any other evaluation in that regards. Now, if there is a problem in the hypothalamus or the pituitary in what we call as central hypothyroidism, the first thing to fall will actually be T4, and the TSH level will be low or inappropriately normal. Now remember, anybody whose T4 is low, we expect TSH to be very high. As a rule of thumb, if TSH is less than 20 in somebody whose T4 is low, we label it as central hypothyroidism. And this is very important because if somebody has a central hypothyroidism, it means that there will be other anterior pituitary hormone deficiencies like cortisol deficiency, like gonadotropin deficiency. And if you start thyroxine replacement without starting cortisol, they will go into crisis, and that could be a life-threatening scenario. The second situation is that you would also need a neuroimaging. So if you have any person in whom you are suspecting hypothyroidism, always do a T4 and a TSH. Do not only do a TSH because you will be missing central hypothyroidism in that perspective. So if you have a T4 which is low, TSH is low, normal, or even less than 20, this is central hypothyroidism. Do a cortisol, do a MRI before starting treatment in that perspective. That becomes important. Now, if there is thyrotoxicosis, the first thing to happen is that the body will say, okay, we don't need to produce thyroid anymore. There would be a suppression of TSH. So TSH is the first marker which will go down in thyrotoxicosis, followed by a rise in T4. And because TSH receptor antibodies will cause stimulation of activation of T4, there will be a rise in T3. There may be situations, particularly in iodine deficient areas, wherein T3 is high, but T4 is normal. So if you want to evaluate comprehensively somebody whom you're suspecting thyrotoxicosis or Graves' disease, do both T3, T4, and TSH. No role of T3 in the setting of primary hypothyroidism. That's something which is very, very clear in that perspective. And what we need to remember is that, as I already said, that TSH is a glycoprotein. Now, it shares a structure with FSH, LH, and HCG. Very high levels of HCG in pregnancy can act on the TSH receptor to induce what is known as gestational thyrotoxicosis. So if you have a lady in pregnancy who has got features of thyrotoxicosis, but who has got no eye signs, no goiter, start thinking of the possibility that this could be a pregnancy-related thyrotoxicosis, which does not require anti-thyroid drugs because that can cause more problems, and we'll discuss this subsequently. Secondly, the TSH levels fall down during pregnancy by typically 1 point. So the TSH cutoffs for pregnancy, as we'll discuss, will be 4 rather than 5 or 4.5 to 5, which we use in normal non-pregnant individuals. And that's an important implications, both in terms of evaluation and management. And this is something which we'll discuss subsequently. So high HCG states like molar pregnancy, multiple pregnancies will cause more elevation of thyroid, causing a thyrotoxicosis like picture in that scenario. Now, once we've discussed that we need to do a TSH, which is a primary test in everybody, T4 also in primary hypothyroidism and central hypothyroidism, and T3 in thyrotoxicosis. The next question is, when should we do the TSH level? Now, there is a significant variation in thyroid hormone. The levels are highest at nighttime, and then they go low in the morning stage. So if you want to detect primary hypothyroidism, theoretically, this 9 to 11 will be a good time. But what is important to remember is that this variation is around 40 to 50%. But the biological variation is very high. The range is around 1000%. So if you have somebody who has come to you anytime in the OPD, if you want to do a TSH and it's very difficult for them to come back the next day, we can do a TSH at any time of the day. This is something you need to remember in that perspective. Very importantly, the difference of TSH in the same individual, the intra-individual variability, is substantially lower than inter-individual variability. Now, what does it mean? It means that if we have 100 people and we measure TSH simultaneously, there will be much more variability there. But if you have the same individual and every week or month you measure TSH, the variability is less. So what it means is that there is a specific TSH set point for every individual. So if you have a TSH of 2 and it becomes 6, it is very, very significant. While if somebody's TSH was 5 and it becomes 6, it will not have that much significance. So having a baseline TSH value can give you a guide whether the levels are going up or down in that perspective. Key message, TSH can be done any time of the day. It has got a long half-life. You can even do it after somebody has taken a tablet in that regard. Now, what levels of TSH are significant? So we all know that as soon as the child is born and there is a huge surge which happens at the time of birth because the child is exposed to a cold environment, the thyrotropin releasing hormone goes sky high, the T4, T3, everything goes up. So there is an elevation of TSH immediately after the birth, which then comes down typically by around 48 to 72 hours. So if you want to do a congenital hypothyroidism screening, the ideal time is after 72 hours or day 3 of life. That becomes important in that regards. Also remember that the cutoffs are age dependent. So don't use these specific cutoffs. Often when you send samples, you will get adult cutoffs on the right-hand side. So that will cause huge confusion. Typically, in the first week of life, if your TSH is more than 20, you start getting concerned. More than 40 definitely require action. 1 to 2 weeks, more than 10 and 20, and beyond 2 weeks, typically 10, you start worrying in that perspective. Subsequently, in childhood, the TSH levels are higher compared to adults. So we use a cutoff of 6 for evaluation and 10 for treatment. Adults, the cutoff become 4.5 in that regards. And finally, in elderly, again, there is a bimodal peak which happens in TSH. In that regards, again, the TSH cutoffs go up. So the key message is that if you are doing TSH for screening of congenital hypothyroidism, either do it at birth or do it at day 3. If you're doing in between because there is an early discharge policy, you have to use a much higher cutoff. And we'll talk about what that higher cutoff is from that perspective. We also need to have a lower cutoff in elderly individuals. For pregnancy, we'll be discussing in much more detail subsequently in that regard. Now, the second major aspect is the measurement of the thyroid hormones. Now, we've got two options. You can measure either the total hormone or the free hormone. Now, total hormones are 1,000 times more compared to free hormones in terms of concentration. They are affected by the thyroxine binding globulin, but their assays are very good. So your T3 levels or T4 levels are very analytical issues as compared to the free hormones, which will be prone for more errors in that perspective. There's also effect of heparin. They'll also be affected on non-thyroidal illness. Now, very importantly, in conditions with effect thyroxine binding globulin, like estrogen, which increase the level of TPG, you may have a scenario of high T4 and a normal TSH. I'll discuss later that it is very unusual for have a high T4 and a normal TSH. Always measure free T4 in that scenario. And this is a normal estrogen response. Somebody who has hyperandrogenism or testosterone exposure will have the other way around, low T4 and a normal TSH. Again, free T4 will be normal. The use of certain drugs can cause a spurious high in free T4, which is not very relevant from a gynecology perspective, but definitely this is very common in the setting of hyperandrogenism. Individuals who are on estrogen or during pregnancy, the T3, T4 levels will go up, and we will have a confusing, conflicting report in that scenario, which happens in that regard. Now, once we have ordered the test, FT4 and TSH, now the second big question which will come is, when should we do the FT4 level? Now, if somebody is not on treatment, doesn't matter, you can do it any time of the day. But if somebody is taking thyroxine, do it before the tablet is taken. The half-life of FT4 is typically very short. So if somebody is taken the tablet immediately and you had done the test, your levels will be high. So don't do FT4 after the tablet, do it before that. Now, how do you interpret? There is a log linear relationship between FT4 and TSH. So as soon as your FT4 goes down, TSH should be sky high. And as soon as FT4 is high, TSH should be 0. So if FT4 is high, TSH should be very high, and we use 20 as the cutoff. This is primary hypothyroidism, problem of the thyroid gland, usually isolated autoimmune problem. You can do a TPO antibody and consider starting treatment. If FT4 is low and TSH is low, normal or below 20, this would be a central hypothyroidism. This is definitely an issue of concern. There could be an issue with regards to CNS issue. So you need to do an MRI, you may need to do a cortisol level, and further evaluation definitely is required in that scenario. On the other hand, if the FT4 is high, the TSH would be 0 or undetectable. This is thyrotoxicosis. If TSH is detectable in this scenario, this will indicate the possibility of a TSH secreting adenoma, very, very rare in clinical perspective. The big message here is that if you have a TSH level which is below 20 and a low FT4, this is central hypothyroidism. You do not start treatment, get an MRI done, get a cortisol, refer to an endocrinologist. Further evaluation and management is absolutely essential. We have developed as part of the MediClasses Gynecology app, a very simple tool in which if you just feed the data, you will immediately get the interpretation with regards to what the levels are in that scenario. This is the thyroid interpreter. So now we have a 32-year-old lady with hirsutism and oligomenorrhea. We are seeing that T3 is high, T4 is high, TSH is normal. So if you go back to the previous slide, if somebody just looks at the algorithm, you will say this is TSH dependent thyrotoxicosis, maybe a TSH producing tumor. That is exceedingly rare. Clinically, the patient is euthyroid. So the next question is the patient on any drugs? And what we found that there was a clear-cut exposure on estrogen progesterone, and that was causing a spurious elevation of T3. Free T4 levels were normal. So anybody who has pregnancy, who is exposed to estrogen or SERMs, you should always do a free T4 rather than a TSH level in that perspective. 28-year-old lady with amenorrhea, clinically looking like hypothyroid, coarse skin, edema, puffiness. TSH was normal on 3 occasions, and going from here to there, no diagnosis made. Now, when we evaluated, we found that the free T4 was nearly 0 and TSH was normal. So what was happening there? This was a case of central hypothyroidism. TSH will always be normal. So if you are evaluating anybody for the first time, always do a FT4 and a TSH. Don't just do a TSH. Otherwise, you will miss in that scenario. So if we go by our application and look at the non-pregnant adult scenario and put in the basic data of a FT4, which is only 2 picomoles per liter, and TSH of 3, you will get a scenario of central hypothyroidism. So basically, we have tried to develop a very simplified tool which looks at 4 specific age groups: neonates, children, non-pregnant adults, and pregnant adults, which interprets, evaluates, and assesses regarding the further management using this thyroid interpreter. So we now discussed about development, becomes very important issue. Then we'll go on to growth, fertility, and pregnancy. So this case, we already discussed, a 22-year-old lady presenting to us with such a bad situation. What could have been done in that scenario? So screening, now this is a big question we'll ask. Should we do screening for somebody who has got a family history, somebody who's got a sibling, or we should do screening for all? This is an important question. I don't think we have a poll option available, but the key message here is that there is a definite role of neonatal screening for congenital hypothyroidism. We, as part of the Indian Society of Pediatric and Endocrinology, have been canvassing and campaigning extensively about routine neonatal screening, which is available in a couple of states in India, but not everywhere. And I'm sure ISOPARB, who is the primary advocate as far as the perinatal part, should have a very, very active role in terms of neonatal screening. And I'm sure a lot of efforts are going on. We need to really double up these efforts so as to avoid these cases in that scenario. Now, what are the pointers to congenital hypothyroidism? This is a common question. And I ask this to pediatricians, even young pediatric endocrinologists, and they will say, okay, hypothermia, prolonged jaundice, bradycardia, abnormal facies, umbilical hernia, and all these edema. The answer to this is that the most common pointer to congenital hypothyroidism is no sign, no symptom. Most neonates, the best pediatric endocrinologists can also not identify in the first 14 days because mother's thyroid is trying to conserve the child. So the most important issue is that we should go for screening, which is essential in every child, irrespective of family history, irrespective of scenario. Screening is absolutely essential in that regard. Now, next issue is after screening, people get confused about what to do with regards to specific cutoffs and how do we go forward from there. So look at TSH levels. If TSH is more than 40 As I said, this is very significant. This should be done in day 3. We need to consider treatment, do a FT4 and consider treatment. If FT4 is less than 20, that's normal, do not treat. Cutoff between 24 to 48 hours is 34. This is from the Indian Society of Pediatric Endocrinology guidelines regarding congenital hypothyroidism. If the TSH is 20 to 40 in the newborn, repeat it at 14 days. Levels more than 20 would warrant treatment. Less than 10 will be normal. If it's 10 to 20, repeat after 21 days. If it's more than 20, treat. 6 to 20 is a bridge. It's like a subclinical hypothyroidism. You need to do a thyroid scan and evaluate, and less than 6, no treatment. So the general rule, if you remember, 40-20-10 or 40-26 in terms of management in the first, second, and third week, that's what requires treatment. Remember, do a neonatal screening in everybody. And if it's more than 40, urgency is there. More than 20, refer to a pediatric endocrinologist or a pediatrician in that perspective. What about growth? Thyroid is not only the major determinant of development, it's also a major determinant of growth in that perspective. So we have got this 10-year-old girl with short stature, height is 102. So it's like typically 4 years in terms of the height. The growth hormone level was very low, referred to us as growth hormone deficiency. For us, anybody who has got severe short stature, before we go ahead with growth hormone, we have to look at other causes, and hypothyroidism is very, very common in that regard. So this child is normal mentally. Remember, congenital hypothyroidism have mental retardation, and this is the most common treatable or preventable form of mental retardation. If we treat in the first 14 days of life, the child will have a normal outcome, but not subsequently. But acquired hypothyroid children do not have developmental delay. So just because they are looking normal, their development is normal, it does not mean that they cannot have hypothyroidism. Anybody who is short, get a thyroid level done, and often you will find shocking results like this in that regard. The other scenario is puberty. 7-year-old girl who had thelarchy, and very soon after thelarchy developed menarche. So she is very, very short, has a large ovarian cyst, and this is unusual. Anybody who has thelarchy typically will take 2 years for bleeding to happen. Second, anybody who has precocious puberty should be tall. This girl is short. So if you have a short girl with precocious puberty, if you have a girl with ovarian cyst, think thyroid. That's a key message coming out here. Bone age is also delayed, and she had definitely breast development with no pubic hair development. And this is again important. Only breast development in menarche, no pubic hair development. This is hypothyroidism because it causes secondary hyperprolactinemia. The LH-FSH levels are very low, and you do not have any pubic hair development. Now, why does hypothyroidism cause precocious puberty in girls? Is because your TSH acts on the FSH receptor. TSH is huge, 1000 levels, and it will then cause precocious puberty, which is peripheral. All you have to do is to give thyroxine, and we have shown in our publication around 10 years ago that if you treat them with thyroxine, everything improves, their puberty improves, the ovarian size regresses in that regard. 21-year-old girl with hirsutism, oligomenorrhea, LH is high, FSH is low. Now, a lot of these people are actually labeled as polycystic ovarian syndrome. Somebody had a prolactin, which was slightly on the higher side, labeled as hyperprolactinemia. Now, remember, prolactin has got a similar regulation as TSH. Dopamine inhibits prolactin, it inhibits TSH. Thyrotropin releasing hormone TRH stimulates TSH, it stimulates prolactin. So if you have an untreated primary hypothyroidism, your prolactin levels may be very, very high. So anybody who has got a high prolactin, get a TSH done in that scenario. So thyroid should be suspected in anybody who has got growth failure, pubertal disorders, rare cases with cardiomyopathy, sodium being low, motor delay, and hyperandrogenism. So these three, growth, puberty, and hyperandrogenism, very commonly will come to a gynecologist, and thyroid should be done in that scenario. Now, how do you approach? If you have done a FT4 in TSH and your FT4 is low, along with that, your TSH is above 20, this is primary hypothyroidism. If your TSH is below 20, this is central, you have to look at MRI and cortisol. If your FT4 is normal, look at TSH levels, which are below 6, it is normal. More than 10, it's primary, and this 6 is for children, you can use 4.5 in adults. Between 5.5 to 10 for adults, look at risk factors. Are there TPO positivity, goiter, family history, female individual, and somebody who has infertility, planning pregnancy, start treatment. All other conditions, wait. If these are not there, follow-up is required. So generally 4.5 to 10 do not require treatment unless there are indications for specific treatment. And definitely we'll talk about pregnancy and planning pregnancy become absolutely important in that regards. Now, this is a very common situation. 12-year-old girl with obesity and the TSH is marginal. A lot of obese individuals, children, adolescents come to us that, okay, our TSH is slightly high. Let's start thyroid and our weight will come down. No, this elevation of TSH is the effect of obesity. It is not the cause of obesity. When somebody becomes obese, the leptin levels go up. They go to the brain, they tell the pituitary, okay, let's produce thyroid to cause burning of calories, but then it stops there. So if you have a TSH less than 10, in anybody who has obesity, do not rush to treat because this is the effect and not the cause of obesity in that scenario. So if your TPO is negative, FT4 is normal, no need of further treatment in that scenario, very importantly. 26-year-old lady, hypothyroidism with infertility, and this is again an important scenario to look at. She is on 250 micrograms of thyroxine and TSH is very high. So this is a very unusual scenario. The typical dose of thyroxine is 1.6 microgram per kg per day. So somebody who is 60 kgs would require around 100 microgram. But she's on 250, TSH is more than 100. So what does it mean? We have to think of possibilities of either a poor adherence. Second, she might be taking some calcium or iron tablets within a couple of hours. There may not be adequate gap between the taking the tablet and the next meal. So we evaluated for compliance, which was good. She had anemia and she was lean. So this is an important association, which I like to highlight to everybody. If you have a lady who is lean, who is having anemia and has requiring a very high level of thyroid dose, always think of malabsorption. Think of celiac disease. So what should we do here? You should do FT4, TTG or TPO antibody. TPO antibody will only tell you that this is autoimmune. It won't help you further. So always consider TTG in that scenario because this could be celiac disease in that regards. And we have seen a good number of individuals with hypothyroidism and celiac. And if you correct their diet, gluten-free diet, they have a dramatic improvement in that scenario. So we are focused on two key areas. Now we'll move forward about the most important aspect that we're discussing today is the impact of pregnancy and thyroid in that perspective. So just a few words as to what happens to thyroid physiology during pregnancy. Now, what we need to understand is that the placenta produces HCG, which we all know, and this HCG acts on the TSH receptor, causing increased amount of T4 and suppression of TSH. So TSH goes down by 1 point with the use of this HCG. And this is important when we decide about cutoffs for pregnancy. There's also estrogen, which is coming into the huge amount from the placenta, which increases the thyroxine binding globulin. So the total T4 will be high, but your free T4 will be normal in that scenario. So they will have a high T4 and a low TSH setting, which may look like thyrotoxicosis. In a way, pregnancy is actually a physiological thyrotoxicosis. So if you have somebody who is hypothyroid, and if you give higher dose, you should not bother. Even if she goes a bit hyperthyroid, she should not remain hypothyroid. That is what is extremely relevant from that perspective. FT4 is clearly the preferred test of choice. In that scenario, it is not affected in pregnancy, but sometimes there may be assay issues. That is more for endocrinologists to worry, not for the routine perspective. Now, TRH can rapidly cross the placenta, TSH cannot, and that's very important. Otherwise, anybody who had a primary hypothyroidism, the TSH will go and baby will develop thyrotoxicosis. So it's very good that TSH does not cross placenta. Very importantly, T3 and T4 cross placenta by around 40%. So fetal levels are around 40% of maternal level. What it tells us is that the fetus requires less amount of thyroid because it's just using it for brain growth. It is not using for physical growth. It's not required. So that 40% is good enough. So this maternal supply will prevent any intellectual delay in the baby and it will last till 14 days of life. So if you have mother whose thyroid functions are normal, even if baby has got no thyroid, will have a normal development in birth, and you've got 14 days to treat, and that's very important. On the other hand, subclinical hypothyroidism, even in mothers, may have an issue in terms of neurodevelopmental outcome. This is very important. So we have to be careful in the first trimester to have a good control of thyroxine in that regards. Now, there is a free passage of TSH receptor antibodies. So if there is a blocking antibody, it will cause hypothyroidism in the baby. If it's stimulatory antibody, it will cause hyperthyroidism in that regards. They go off by around 8 to 12 weeks. Their half-life is 2 to 3 weeks. The antithyroid drug methimazole crosses quickly. So you will have an initial phase of hypothyroidism in an infant of Graves' mother. So if the mother is on Graves' disease for treatment with methimazole, your levels of thyroid will go down because of this antithyroid drug, and then they will rise again because of the antibody. So you have to monitor thyroid function in those babies at day 3 and day 14 of life. Now, the next issue importantly is that the TPO also has a direct effect on placental function. So it's been shown that even if you are euthyroid and your TPO levels are high, there may be a chance of placental insufficiency, progesterone deficiency. So there is some theoretical role of giving progesterone to prevent miscarriages in somebody who is autoimmune hypothyroidism. This is more like a few studies. We need much more evidence to come up, but there are indications that TPO also has a direct effect on the placenta, causing fetal demise. Now, as we have discussed, there is a leftward shift in the TSH levels. So as we can see from this wonderful study, which shows that the TSH concentration goes towards the left. So your TSH goes down in the first trimester, and by the time you come to second or third, they become normal in that perspective. So 7 to 12 weeks, the American Thyroid Association recommends a level of 0.1 to 4 as a normal TSH, and subsequently you can go ahead with the non-pregnant levels in that regards. So thyroid functions in pregnancy, you will have low TSH 0.1 to 4. T4 will be 50% higher if you're using a total T4. So if you're using a total T4, use a pregnancy specific range or multiply the range by 1.5 times. FT4 will be slightly lower in that regards. So why are we bothered? There are effects of hypothyroidism in terms of fetal demise. So if somebody's thyroid is very high, now often patients will come to us with TSH of more than 100 and they will say, what to do? Shall we go ahead with an abortion in that scenario? Definitely not. Because if you start at the right time, there may be abortion might happen spontaneously, but you don't do abortion to prevent miscarriage. There will be no intellectual outcome inabilities if you treat at the right time at the right dose. So even if TSH is very high, you start treatment, the baby's outcome will be good because by the time the neurodevelopment happens, you should be able to get the thyroid levels normal. There would be effects on prematurity and asphyxia, which is preventable. And of course, there may be issues of long-term intellectual delay, which we'll discuss a bit subsequently. Now, the next issue is how much these thyroid antibodies affect miscarriage and preterm birth. And studies show that there is a slight effect of maternal TPO antibody. And this is what I'm trying to say is that even if you have a euthyroid individual and TPO is positive, especially in the setting of an artificial reproductive technique, the ATA recommend that we may consider treatment between 2.5 to 4. So this is some controversial area which I'm coming to, but we'll discuss this in more detail. If your TSH is 2.5 and below, nothing to worry. 2.5 to 4 with TPO positivity, ATA says that, okay, if you have done ART, consider starting treatment of thyroid in that scenario to prevent miscarriage. What about the outcome of subclinical hypothyroidism in pregnancy? The most controversial area in that scenario, there is definite evidence that subclinical hypothyroidism has multiple effects with regards to adverse neonatal and maternal outcome and should be treated. Now, the question is what cutoff, what dose, how to treat, that will be the issue. Now, this was a landmark study from NEJM, which looked at the neurodevelopmental outcome with regards to children who are born with hypothyroidism. And they clearly said that even subclinical hypothyroidism may have an adverse effect on long-term outcome. But this is if you have not controlled by around 8 to 12 weeks. So what we want is immediate diagnosis, start at a high dose, correct it as soon as possible, and you will have no problems in that perspective. And this was an interesting study which looked at somebody who has a subclinical hypothyroidism, again an AGM study, and treating pregnancy. So if you start treatment between 8 to 2 weeks, 20 weeks, there may be not much improvement. So better is to start treatment immediately. So that's why if there are high risk situations, get a TSH done right away, start treatment. If you treat beyond 8 weeks, you will not get much benefit for subclinical hypothyroidism. So if you're picking subclinical hypothyroidism to improve neurological outcomes, start treatment by 8 weeks. That's the best scenario in that regards. Now, having discussed the overall evidence of the impact of hypothyroidism on pregnancy in terms of infertility, in terms of miscarriage, in terms of newborn outcome, how do we approach a case? Now, the American thyroid guidelines really say that you do not need to do TSH in everybody. There was a lot of controversy there, but they said that if there is history of miscarriage, family history of autoimmunity, age more than 30 years, infertility and infertility treatment, and family history, then you do a TSH. If your TSH is less than 0.1, this is clearly a case of thyrotoxicosis. If it's above 4, you do a FT4. If FT4 is normal, start at 1 microgram per kg per day. If it's low, start at 1.6 microgram per kg per day. If your TSH is 0.1 to 2.5, nothing to worry. This is normal. If it's 2.6 to 4, TPO negative, follow up. TPO positive, start around 50 micrograms. So the key message is here is that not everybody will require evaluation. TSH 0.1 to 2.5, nothing to worry. 2.6 to 4, TPO negative, no treatment. More than 4 or 2.6 to 4 with TPO positivity, consider treatment. Higher doses for somebody whose FT4 is low, lower doses for somebody whose FT4 is normal. And if the TSH is less than 1, the 0.1, definitely the treatment will be required from that perspective. So this is a very, very important and a crucial scenario which is there, which we need to look at. That will basically suggest that if you have a scenario of TSH which is between 2.6 to 4 and TPO is positive, there may be a role of treating by 50 micrograms. Don't start at 25, start at 50. That's the minimum starting dose in that scenario. So we'll now run through a few cases which will take us through this algorithm. 28-year-old lady with overt hypothyroidism, thyroxine 75 for 2 years, TSH is 4.2. Now she is planning pregnancy. What should we do in that scenario? Now, if we look at this, ideally we want the levels to be less than 4, and if it's less than 2.5, that will be excellent. So we need to definitely increase the dose. Now, a 24-year-old lady with primary gravida and pregnancy, normal conception, no goiter, no family history. Do we need to do a thyroid assessment? Do we need to do a TSH? Do we need to do a FT4 TSH or a FT4 TSH and TPO? Now, if we look at the guidelines, clearly this lady does not require an evaluation because there is no miscarriage, no autoimmunity, no family history, age is 24 years. So routine thyroid assessment is not required in clinical perspective. That will cause more confusion in that scenario. So no evaluation is required. 25-year-old lady, pregnancy of 9 weeks, T3 is high, T4 is high, and TSH is high. So this is a unique situation. Everything is high. So we all know that pregnancy, we need to use a 1.5 times cutoffs in that perspective. Free T4 levels were normal. It looks more like a TBG excess. So this is a classical case of hypothyroidism, primary hypothyroidism. We have to definitely treat in that scenario. So this highlights the importance of assessing pregnancy-specific cutoffs in that scenario. 28-year-old lady, pregnancy 6 weeks, on 75 micrograms of thyroxine, has thyromegaly and a high TSH. Now, this is a common question. Somebody with a TSH of 32, 100, what do we do? Shall we go ahead with miscarriage? Shall we go for abortion? This is a common question in their minds. They always ask about that. Now, do we stop LT4? Of course, that's out of question. Increase to 100, increase to 150, or consider abortion in that scenario. So we need to understand, and this is our management pathway, which really turns out, so she's hypothyroid and the TSH is more than 20. We should increase the dose by 75 to 100 micrograms. So don't do half measures. We have to hit early, hit hard. So if you're coming with TSH of 32, okay, if we control it now, we can prevent the mental development. Remember, 8 weeks was the figure we talked about. So if you start by 150, you increase the dose, you should be able to take care by 2 weeks time. And that's what you want to target. And target will be 2.5 in the first trimester and 3 in trimester 2 and 3 in that regards. 24-year-old lady with primary gravida pregnancy, FT4 is 12, TSH is 3.8. So this is a scenario, normal thyrox FT4, TSH is 3.8, there is no goiter, TPO is negative. Now what should we do? Nothing, thyroxine of 25, thyroxine of 50, or thyroxine of 75. Now if we look at our algorithm, it clearly shows is that if you have our TSH between 2.6 and 4 and you do not have a TPO positivity, no need of treatment. So TPO is an important indicator for need of treatment in that scenario. So not required in this setting. 24-year-old lady with pregnancy, 6 weeks, screening was done, TPO was 300, TSH is 3.2, thyroxine is normal. What do we do? Shall we observe, do an ultrasound, start thyroxine at 25, start thyroxine at 50? So if you again go at our scenario, we should better to start with thyroxine of 50 micrograms. So TPO positivity, TSH 2.6 to 4, start treatment, but don't start at homeopathic dose, start at 50 micrograms in that scenario. That's very, very important from that regard. Now we'll move from hypothyroidism to thyrotoxicosis, because this again is an important scenario which we are seeing much more commonly in practice. So a 30-year-old lady with Graves' disease on methimazole, controlled thyroid levels, had pregnancy, advised medical termination. And this was unfortunate. This was many years ago, and then she never conceived. So this is a scenario that we do see Graves a lot. There is a very good way of achieving fertility, good outcome in that scenario. We need to be positive rather than negative in that scenario. So if you have an individual with Graves' disease, if somebody is on 10 milligram, 15 milligram, we try to stop their treatment. Otherwise, if the dose is high, we expect that remission will not happen. We will advise for a radioactive iodine treatment and then wait for 6 months for pregnancy. Very importantly, if somebody is accidentally becoming pregnant on methimazole, which is the drug which we use very commonly, we then switch to propylthiouracil in the first trimester because of a theoretical concept of lower risk of malformation with PTU. This is important, and after first trimester, we go back to methimazole. Now, why don't we use PTU? Otherwise, is that there is a very high risk of hepatotoxicity. So the only indication where propylthiouracil is used currently is in individuals in the first trimester of pregnancy. Otherwise, nowhere we use that in that scenario. 1 milligram of methimazole is 20 milligrams of PTU in that interchangeability. So 26-year-old lady with Graves' disease, planning pregnancy on 30 milligrams of methimazole, she still is thyrotoxic. FT4 is still high. What do we do? Shall we go ahead with pregnancy, defer the pregnancy, or go for radioactive iodine? So we have already discussed that if you are on low dose, 30 is a big dose. I don't expect this to go down. Still the FT4 is high. So we should go for radioactive ablation, wait for 6 months before planning pregnancy in that scenario. Again, a 28-year-old lady with methimazole of 40, and you see a large goiter, wants pregnancy, still thyroid is not very well controlled. What should we do? In this scenario, radioactive iodine may not be effective, and maybe we have to go for surgery, but stabilize the patient before you start surgery and do the surgery before you go ahead with pregnancy. So I think very important, we have to decide when not to go on pregnancy in somebody who has Graves' disease in that scenario. A 26-year-old lady with pregnancy presenting with tremors, tachycardia, thyroxine FT4 is slightly high, TSH is low. So this looks like thyrotoxicosis. Now there is no thyromegaly, there are no eye signs. What do we do? Shall we do a thyroid scan? Shall we do an ultrasound? Shall we start PTU or observe? Now this is a very common scenario which we are seeing. I've already discussed that pregnancy is a physiological thyrotoxicosis. So there are two possibilities in somebody who comes to you with increased thyroid function during pregnancy. One, it could be because of the HCG effect, or second, it could be Graves' disease where your TSH receptor antibody is hyperactive. So HCG effect or gestational thyrotoxicosis versus Graves. So if you have no eye signs of goiter, mild disease, think of a gestational thyrotoxicosis. If you have eye signs in goiter, severe disease, think of Graves. In Graves, you have to give antithyroid drugs. In gestational thyrotoxicosis, you do not need to give drugs. So in this lady who has got no eye signs, no goiter, mildly high FT4, wait and watch. Do not do a thyroid scan, of course, because that's contraindicated in pregnancy. Ultrasound is not going to tell you much. So if you do not have an eye sign, do not have a goiter in somebody whose thyroid function is slightly high, think of gestational thyrotoxicosis, observe and monitor in that scenario. 28-year-old lady with Graves' disease, methimazole 20 milligrams per day, now accidentally became pregnant. Often happens, you've told them not to get pregnant, but they have become pregnant. What do you do? So here you have to switch to PTU, increase dose, decrease dose, switch to PTU. So we already discussed that in the first trimester, in thyrotoxicosis, if you are on methimazole, you switch to propylthiouracil in a dose equivalent of 1 to 20 in that regards. And that's what you want to do. Now at 24 weeks, you find that methimazole is 20 again, you start back. There is thyrotoxicosis. Now there is a fetal tachycardia. Now remember, if mother is thyrotoxic, the antibodies will cross the placenta. From 12 to 14 weeks, the fetus may become thyrotoxic. And the only sign you will see is a very high heart rate. So you have to be very, very cautious. You may develop a fetal hydrops also. So what do you do here? You increase the methimazole dose in the mother. That will also cross the placenta and that will really reduce in that. So monitoring of fetal heart rate is very, very important in that scenario. So increasing dose will clearly work. So monitor for heart rate in a fetus of mother who is thyrotoxic. Now you had an uneventful delivery of a girl. Day 3, the TSH was normal. The NFT4 was normal. Now at discharge, she came back again day 13 with significant weight loss, and you had severe florid thyrotoxic state. Now there is a 2% chance of infant of Graves' mother having thyrotoxicosis. There is a 2% chance of having hypothyroidism. So 96% will be normal, but these 2% may have a significant implication. Now remember, this lady was also on antithyroid drug. So that antithyroid drug is there for the first 2 weeks. That time the baby had a normal thyroid function. Once its effects goes off, the TSH antibody starts to act and then your Graves comes up. So if you have a newborn born to a mother with Graves' disease, get a thyroid function test done at day 3 and day 14. That is a life-threatening condition and you have to treat immediately with beta blockers, digoxin, neomercazole. All those things are required in that scenario. So key message, if there is pregnancy with thyrotoxicosis, monitor fetal thyroid functions at day 3 and day 14 of life in that scenario, and that becomes important. Now, I think final case scenario, 30-year-old lady postpartum, tremors and weight loss. FT4 is high, TSH is low. So is this Graves' disease? No, this is a common scenario of what we call as postpartum thyroiditis. There is basically an inflammatory destruction of thyroid. The thyroid hormone, which is there for 2 months, is released. So there is a thyrotoxic stage, which goes into hypothyroidism, and some may even recover. So there will be no goiter, no eye signs. Again, key message. No goiter, TPO positivity. So what do? We give PTU, beta blockers, thyroxine or thyroid scan. You can do a thyroid scan, which will show a decreased uptake. So no goiter, no eye signs, post-pregnancy, your levels go up. This is clearly a postpartum thyroiditis. Again, a benign condition in that regards. This is common in individuals who have TPO positivity. There is no goiter, hyper followed by hypo, and then euthyroid. So you have to follow the course in that scenario and they will remit over time. So I think this was a long talk, but we tried to cover the entire spectrum, right from the newborn period to childhood, to adolescence, to pre-pregnancy, pregnancy, and hypo and hypothyroidism. We used so that hopefully it will generate a lot of interaction. All these videos and recordings are available on our website, learning.growthsociety.in, and my YouTube channel. You can have access there. We can also have a look at our courses which are available there, and our mobile application available both on Android and iOS platform in that scenario. So I'll thank the entire audience for a patient hearing, and thank the team ISOPARB Kanpur for this wonderful opportunity. Thank you.
Thank you, Dr. Anurag. You have done a wonderful job. That is why it was my dream to go on through this, because many of the times, and today we, at least the doctors who are logged in, we must take a promise that we must go for every child to be screened at about 5th day of life for the thyroid function TSH. It is very important. Otherwise, the mental retardation we can stop and जब आपको वो बच्चा देखने को मिलता 18-20 साल में। मैंने एक बच्ची आपके पास भेजी थी कन्नौज की, ऐसी थी जो आपने पिक्चर दिखाया था। तो रियली देन यू आर वेरी मच पेन्ड एंड व्हाट जस्ट टू थिंक अबाउट द पेरेंट्स ऑफ दो चाइल्ड। इट इज द गलती हमारी है और सफर कोई और कर रहा है, तो इट इज रियली वेरी शेमफुल फॉर अस इफ यू जस्ट थिंक कि अगर हमारे साथ ऐसा हो जाए तो हाउ डू विल फील द थिंग्स व्हिच वी कैन अवॉइड। तो ये तो एक आध प्रॉमिस देने का बनता है कि भी हमारे पास सबके पास न्यूनेटोलॉजिस्ट होता है। मोस्ट ऑफ द पीडियाट्रिशियन डॉक्टर अनुराग आई कैन टेल यू दे डोंट गो फॉर इट। हमको कहना पड़ता है डॉक्टर साहब प्लीज करा लीजिए, पता नहीं वो क्यों इतनी अच्छा प्रॉब्लम ये होती है जब हमने बच्चा निकाल के दे दिया तो वो पीडियाट्रिशियन की ज्यादा सुनते हैं, तब भी हम काफी कुछ कहते हैं आई गो नहीं आप कराइए इस चीज को। तो ये चीजें बहुत इंपॉर्टेंट हैं। और आज आपने मुझे लगता है विनीता यू जस्ट गो फॉर क्वेश्चन, तुम्हारे काफी क्वेश्चन का आंसर दे दिया डॉक्टर अनुराग ने। आई एम वेरी मच श्योर। डॉक्टर अनुराग एक क्वेश्चन मेरा आपसे, उसका विनीता जाएगी। सपोज करिए किसी का लेवल अगर 3 है और वो पहले ऐसे ही आ गई अपने से करा के, कोई कंप्लेन नहीं कुछ नहीं है, शी इज प्लानिंग फॉर प्रेगनेंसी, तो क्या हमको उसका लेवल 2.5 रखना है कि नहीं रखना है? नहीं ना?
नहीं, no, not required, ma'am. So if somebody is already hypothyroid and on treatment, so then we should plan to keep it on the lower side, but otherwise she's absolutely normal, so nothing to worry about.
ठीक है विनीता, you go. Vinita, you just
Dr. Anurag, nowadays it is a guideline on every baby third day we get serum bilirubin and thyroid done. This is a guideline, pediatric guideline, I think, na, for every baby.
Ma'am, this is a standard guideline, and we have been working with the government that they should do it in everybody, but unfortunately वो हो नहीं रहा है. We have been doing it, so I am doing it with the Foxys across the country, much more with IAPs. So hopefully people are doing, but still it's a practice which needs to change. That is important. So
it's the World Health Guidelines, yes.
ISOPARB member will come first, then everybody will come. Vinita, you please go.
Before we go for the question answer session, we have got our expert Dr. Kiran Pandey, madam. Ma'am, over to you, Dr. Kiran, ma'am.
Yes.
For your expert.
Thank you, Dr. Sangeeta. Thank you. Although Dr. Kiran Sinha has done most of my work already, she was so much impressed and so much awed by the lecture that I know her emotion. I mean, the things came out, and she has already concluded it. Still, I would appreciate Dr. Anurag has done wonderful wonders to the thyroid. He has covered from the day one, from the neonate up to the reproductive age group, and very important points he has covered in precocious puberty. That is one very important thing, that the small age, just a minute, the young the girl coming with the precocious puberty, with short height, with ovarian cyst. That was one case even I had once. So I do remember it perfectly, that you give treatment and that this big cyst disappears without doing any surgery, which otherwise you feel कि बहुत बड़ा है और करना पड़ेगा, all that. So one has to be very careful. The only, I think, one aspect I would like to focus, which was obviously because it was not the point of view of endocrinologist, our young girls should remember that it's also a very important cause of menstrual irregularities. In fact, in 25 to 65% of the girls, the hypothyroid is a very important cause of menstrual irregularities, the oligomenorrhea also being one of them, and even the menorrhagia. Then they come to the reproductive age group, of course, before the patient conceives. Even the infertility is also an issue with the hypothyroidism. The anovulatory cycles are very common. The luteal phase defects are very common, and because of hyperprolactinemia being associated with thyroid, again the prolonged cycles and the anovulation are also the issues. So I mean, these points also have to be seen in these cases. Reproductive, as very rightly said in the subclinical hypothyroidism, how to be treated, the importance of TPO antibodies. No one can do justice more than Dr. Anurag, because he has covered each and everything. The only one more point I would like to focus, that is on the later elderly age group and the postmenopausal women also. That is one part. Of course, it was such a big lecture. That's why there was no time for that. But that point also everyone should remember, that there are many, good amount of percent, I think around 6% cases where 6 to something more than that, where the hypothyroidism remains undiagnosed in cases of postmenopausal women, and even sometimes overt hypothyroidism, and even sometimes subclinical. And the most important reason is the clinically also there is a clinical picture also is a very confusing, because many times that sweating, that anxiety, that palpitation, those are the symptoms of hypothyroidism or even hyper. Sometimes they do resemble the postmenopausal symptoms. So there is a definite percentage of cases which are being missed in these cases. So that's also one has to remember, and they do need our attention. And the weight gain, they do remain weight gain issues also with that. As such, the pituitary functions are decreasing, the estrogen is decreasing, and that is also the thyroid is increasing. So these points we can edit. And of course, the hyperthyroidism, I feel always is a bigger challenge, because here like in hypo, as Dr. has also said, many a times you can control it. There's no need to termination unless and until something actually has happened and you are able to evidence it. Otherwise, hyperthyroidism is a more challenging situation, where correction is must before the conception. That's ideally. Otherwise, there might be chances of increased abortion, prematurity, and of course the other problems. So take care of it. Don't go for hose. Hit it with the as the situation is, and you can save the baby and the mother both. Of course, the monitoring has to be done from medical legal point of view also, and otherwise also you have to see these patients with all that double marker and the NT&B scan and the congenital, the level 2 and even level 3 scanning has to be done. Everything has to be done, and still you have to say you cannot predict the mental retardation ever. That functioning part we can never see. We can only see the structural effects. So with these issues, counseling of the patient and taking the confidence of the patients are very important. These were the few small issues which I thought we can either to finalize it, and taking the patient up to the age of elderly, that becomes very important. So
I think
that's all.
that was a very relevant point you added on menopausal group, which I couldn't do because of the long term. The only message there, just to
I
add,
know
is
it's
that
a long term.
the only message that TSH levels tend to be higher in elderly, and often they have a cardiac. So we should not consider thyroid TSH more than 8 will be significant, and more than 12 will be requiring treatment. So this is a message for older individuals, because otherwise we may cause more harm. But definitely,
yeah, and there I think Dr.
Yes.
Anurag, the doses have to be increased slowly.
Yes.
You don't have to hit hard like the reproductive age. That's
very, very
also
clear.
another important message, that you increase it by 12.5 and 25, not like that 50 or 75.
Otherwise, they go into
Dr.
angina.
Anurag, at what age you consider it should be? After what age? After 50 or?
No, not 50. So it is like much older. So Western people,
like
they talk about
60.
60 plus.
65, you should consider not more than less than 8 to 12, right?
Yeah.
Dr. Kiran ji.
Yes, madam.
हमने तो अपने मीनोपॉज सोसाइटी में एक बार बुला लीजिएगा, और पूरा जो रिप्रोडक्टिव ये छोड़ करके मीनोपॉज वाला ये जो है वो बहुत जरूरी है. वो एक अलग टॉपिक हो जाएगा पूरा. हाँ, एक करा लीजिएगा पूरा.
इसीलिए मुझे लगा कि वो मेनोपॉज वाला पॉइंट मुझे
जनरली लोग ओवर करेक्शन कर देते हैं मेनोपॉज में.
असल में इसमें दो डीले थे.
That should be very careful.
Yeah. नहीं तो एंजाइना वगैरह होने के चांसेस ज्यादा हो जाते हैं अगर आप एकदम से स्टार्ट कर दो। तो आप मेनोपॉज सोसाइटी में एक बार फिर बुला लीजिएगा।
चलो विनीता क्वेश्चन पूछो।
Sir, continue with this menopausal patient of hypothyroidism. Is there any relevance of anti-TPO antibody in these patients?
Yes, yes, Dr. Meera. So basically the management is nearly the same. So if your TSH is more than 12 and your FT4 is normal, then also you should treat. So the cutoffs have changed, but 8 to 12 TPO will have a role on that.
So one question is there, although the question box is almost empty because you have given the answer of all the queries. But one question is this, is especially in the first trimester when TSH is low and FT4 is high, as is the gestational hyperthyroidism, when we have to repeat this one after 4 weeks, 6 weeks.
Yeah, so this is important. So generally it will take up to 6 weeks for things to stabilize. If the levels are very high, so when should we treat? When are we worried? If your FT4 is 2 to 3 times higher than the upper limit, then I am going to be very bothered. If it's like, let's say the normal limit is 20 and it's like 40, 50, I would probably start considering treatment right away. If there is goiter, if there are eye signs, I'll probably start treatment right away. Now there are TRAB antibodies available, which is TSH receptor antibodies, which will also tell you whether this is a likelihood of Graves' disease, then we should treat. But if it's 20, 25, 30, I would wait for 6 weeks and wait for clinical features. So if the clinical features worsen, we will consider early.
Sir,
but
most of the time we have got a patient who have low TSH with high FT4 without any clinical symptoms. And after 6 weeks, again the TSH is low and FT4 is high, then what should be done?
If it is
should it refer to the endocrinologist?
Yeah, if it is Graves' disease, it should have increased dramatically by that time, because Graves' disease also tends to increase during the first trimester of pregnancy. So it is most likely a waning effect which will happen. So by around 8 to 12 weeks of pregnancy, you should usually settle down. That's how the gestational thyrotoxicosis behaves. So if your FT4 is 24 and 24 now also, nothing to worry. If it's like
even if at the 16-week TSH is low, FT4 is again the high side, then
at 16 weeks, probably we are going out of that HCG phase. So we have to think of treating at that 16 weeks. But 6 to 8 weeks after diagnosis, I'll wait. But 16 weeks, I may start at a low dose in that scenario.
If continuous TSH is low and FT4 high, we have need a consideration of endocrinologist advice.
Anti-thyroid drug will start. After first trimester, we can start, because then the problems of hypothyroidism become less. The major problem of hypothyroidism start in the first area. So I would like to avoid that. But 12 to 16 weeks, I'll start treatment. Now, the other big issue is that if there is Graves' disease, the fetal thyroid matures by around 14, 15 weeks. So this is the time when thyrotoxicosis will happen in baby also. So in that scenario, best to treat at 16 weeks with a lower dose.
Okay. Sir, it happens very practically in our OPDs also. When patient comes just for the treatment of infertility, the TSH level is normal and next cycle she will conceive. Then we have to repeat TSH or not?
If the TSH is normal and there is no features of autoimmunity, generally it is not recommended. But if there is a clear-cut infertility treatment you have given, you should ideally do it again. I would say it is a better practice to get it again. Often you will find it to be normal, but if it is going high, then it is better to treat. If you go by the American Thyroid Association, they say that infertility, you should get it done. So I would say getting done is better. One should be twice bitten or once shy. That will be important for that.
Okay. Sir, one question from our doctor in our audience. They had asked about what is the relation of hypothyroidism and less lactation in the postpartum period. Is there any relation? They have written it, the patient of hypothyroidism is having difficulty establishing lactation.
It is not a physiological aspect from that perspective. If you have uncontrolled hypothyroidism, you expect prolactin to be higher, and often galacturia is a common feature which presents with young girls and the primary hypothyroidism. So I would not really associate this with lactational abnormalities. It may be the overall situation, but not because of hypothyroidism.
One question is again from audience. Is there any relation of mastalgia, depression with hypothyroidism?
Yes. So there are a lot of studies in terms of dysthymia, mood disturbances, and abnormalities with subclinical hypothyroidism. So I said if your TSH is between 4.5 to 10, what are the indications of treatment? One is TPO positivity, pregnancy, planning pregnancy, goiter. There is also a consideration of dysthymia. So if somebody has mood disturbances, we can start considering at a low dose of thyroid at that point as well, because this is an association, or whether it is an association or a causation is a different question altogether. But there is an association of borderline high TSH with mood disturbances.
Okay, thank you, sir. Sir, one question is that one patient is having a hypothyroidism during pregnancy. She was treated with Altroxin, almost 50 microgram. After delivery, for the last 3 years, she is having normal TSH. But she has some menstrual irregularity. So she stopped the drug because she said that my TSH is normal. Then what should be done? Should we do for the anti-TPO antibody?
You see, if normally if you have stopped the treatment, and the best way would be to follow up with a TSH level after 6 weeks and see whether it is rising or not. If there is hypothyroidism, 6 to 8 or 12 weeks maximum, the TSH will go up. So at that visit, you can do a TSH and TPO both to have a final decision on that. Often we see that since in a way we can say pregnancy is like a sieve through which if somebody passes, somebody with subclinical hypothyroidism will become overt, and then it will go down. It's just like gestational diabetes. So there may be reversal also. So it may be genuine to stop treatment and see after 6 to 8 weeks the TSH and TPO, and you will get the final figure in terms of what is happening to her.
So most of the time patient खुद से stop कर देते ना, हमारे तो advice वो delivery हो गई उसके बाद वो कभी possible, और वो ये होता भी है कि लगातार TSH ही कराते हैं. लेकिन अगर पेशेंट को मतलब प्रैक्टिकली फिर से कोई मेंस्ट्रुअल प्रॉब्लम हो रही है तो वी शुड गो फॉर टीपीओ एंटीबॉडी.
नो, अगर TSH नॉर्मल है तो बहुत ही अनलाइकली है कि टीपीओ की वजह से मेंस्ट्रुअल इरेगुलरिटी होगी. टीपीओ की वजह से प्रेगनेंसी पे इफेक्ट हो सकता है, बट आई वुडंट एक्सपेक्ट दैट इफ योर TSH इज नॉर्मल, इट इज नॉट द कॉज of abnormal menstruation, just if TPO is positive. So it is not recommended.
Sir, one more question. It is again about a patient. A patient is having low TSH and low FT4, as you said in the central hypothyroidism, and patient have a menstrual problem. She's a very heavy menstruation, irregular menstruation. Is it possible?
Yes, it may be possible, because central hypothyroidism doesn't always need to have a gonadotropin deficiency. There will be anovulation which can happen. There may be hyperprolactinemia because they may have a tumor which is producing prolactin and causing suppression of thyroid. So this is a very, very tricky situation. If you have a TSH less than 20 and a low FT4, this is central hypothyroidism. You have to look at the whole picture. You can have a wide other phenomena. Often we see this in Sheehan syndrome. But we also see, because of other prolactin-producing tumor causing a compression, a non-functional lesion causing a compression. So all those things can also happen.
Okay, thank you, sir. Someone had asked about the mestalgia and relationship of hypothyroidism.
So as discussed earlier, that if you have uncontrolled hypothyroidism, the thyroid TSH also has the effect on the breast tissue. So we do see many, in fact, if I talk about my experience in boys, hypothyroidism is an important cause of gynecomastia. So when we are looking at gynecomastia in boys, we always look at hypothyroidism. So similarly, if you use that analogy, you will have some breast tissue increase which will happen with hypothyroidism, because TSH will act on that receptor as well. Second, your prolactin will go up. So that may also cause some issues. So yes, there will be association in that scenario. But 5 to 10, whether it is going to cause that, I would not be very much. If it's very high, it will cause, but 5 to 10, I would not treat just for mestalgia.
Dr. Anurag, what is although it is a very silly question, what time gap should be there? Patient, they ask, between taking the tablet and taking a tea or breakfast.
Yes, ma'am.
What is the?
So, ma'am, ideally we say 45 minutes is the ideal time. Minimum 30 minutes is what.
Minimum 30 minutes. Okay.
What cutoff value of free T4 you take, Dr. Anurag? Cutoff value of free T4.
Okay, cutoff value of free T4 will basically be age specific, but generally if you're using a picomole per liter, we generally use a figure which is less than 10 as significant. If you're using nanogram per DL, that will be somewhere around less than 0.8 will be the figure.
Dr. Anurag, one more question that you've said about central obesity that the TSH will be less than 20. So we find so many patients who are having TSH less than 20. So are they all central hypothyroidism?
Yeah. So there are two things, low FT4 and a TSH less than 20. It is very, very unusual that FT4 will be low in most cases of that. So most cases that we see with TSH less than 20, FT4 will be normal. So the basic phenomena is that if FT4 is below the range, your TSH should actually be more than 100 in most cases. What studies have shown that it will always be more than 20. If it's less than 20, you have a 90% chance of having a central hypothyroidism. So that's why we use a cutoff. The caveat is low FT4. Normal FT4 and TSH less than 20, it is simple subclinical.
So low FT4, how much low? Below which level?
Below the range 0.8, as I said, nanogram per DL or 10 picomole per liter.
Thank you, everyone. And we have all enjoyed a great session on hypothyroidism, a poignant enigma for our womanhood. On behalf of ISOPARB Kanpur Society, I extend my sincere regards to each and everyone. My very sincere gratitude to our speaker, Dr. Meera Agnihotri ma'am. It is also my privilege and honor to heartily thank our National President ISOPARB, Chief Guest, Professor Gangadhar Sahoo, sir, for sharing his blessings. Our gratitude also to our guest of honor, our National ISOPARB Secretary, Dr. Pragya Choudhary, for her valuable inputs. A lot of hard work and sincere efforts have gone behind this great show, and today is our enlightening session. So all applauds to our convener, Dr. Kiran Sinha ma'am. We have just experienced the rich oratorship of our brilliant speaker, Dr. Anurag Bajpai. Hats off to you, Dr. Anurag, for your knowledge and dedication. We can't thank you enough for your excellent deliberation. My heartiest gratitude to our expert, Dr. Kiran Pandey ma'am, for all her valuable updates as the icing on a cake. My acknowledgement also to our dynamic who are wonderful in knowledge sharing. A big thanks to Dr. Sangeeta Arya for moderating the session so efficiently and smoothly. And our sincere thanks also to Dr. Vinita Avasti, enthusiastic and intelligent treasurer ISOPARB. We are grateful to all our delegates who have joined in and added to the success. And without the support of our pharma friends, this grand CME would not be possible. Our heartiest thanks to Jagsonpal people, and we call it a day. So thank you, everyone.
Thank you. Goodbye.
Thank you, Anurag, once again.
So thank you all very much from Jagsonpal, and we just take this opportunity to connect with all the gynae present here and a product which will be of interest to you all.
Introducing, for the first time in India, Micronized Dydrogesterone, DIVATRONE. For a safer and smoother journey to motherhood, Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for DIVATRONE.
We look forward to your support to DIVATRONE, which is the only brand available which has a shelf life of 36 months, as the API is being made by Jagsonpal. Our other products are Maintain Injection 250 and 500 mg and Lycorid Preg Sachet of L-arginine, DHA and lycopene for high-risk pregnancy. Please join us again on 7th of June for yet another program, which will be on research methodology. Webinar ID is displayed. Please do register. Thank you all very much.